As women approach menopause, hot flashes are increasingly common. They begin suddenly, with warmth coming from the inside out, starting usually in the neck and head. The ears and skin can get red. Palpitations may occur. Sweating often accompanies the flash, and within 5 to 10 minutes it's gone, leaving the woman cold and clammy. History should be directed toward elucidating possible causes. Age, plus the symptoms of declining estrogen, including hot flashes, vaginal dryness, decreasing frequency and flow of menses, would all point to menopause. Thyroid disease is another possible cause of hot flashes. Infections such as tuberculosis or HIV could be possible etiologies. Malignancies certainly can cause hot flashes as well, especially lymphoma and solid tumors. Medication side effects is another possibility, with SSRIs being the most common culprit. On physical exam, note the vital signs. You're going to be looking for an elevated pulse, perhaps an elevation of temperature, blood pressure changes as well. As far as the weight, whenever there's a sudden loss in weight, one might be thinking of cancer, or elevations in weight, one might be thinking of thyroid issues. With perimenopause hot flashes, the cause is usually clear after the history alone. However, this is not the case. Careful examination for peripheral lymphadenopathy or other signs of thyroid disorders such as flakiness of the skin, coolness of the skin, hair that's falling out might be signs for other issues. Certainly any signs of infection or signs of solid tumors would lead you down a different road as well. If the age and history are typical for menopause, no labs need to be done. However, if the patient is having hot flashes at an age that is not typical for menopause, FSH levels can be useful in identifying ovarian failure. TSH should be ordered if thyroid disease is a possibility, but usually in history and physical will lead you to your diagnosis, and treatment can begin on that basis alone. For mild menopausal hot flashes, the first line of treatment is behavioral. You're going to want to layer clothes up and down to stabilize that unstable internal thermometer. You can avoid triggers such as alcohol and caffeine, which can initiate a hot flash. Lowering the room temperature has been shown to help as well. As far as homeopathic or over-the-counter type prescriptions, there are a number of things that have been tried and are used by many women over the counter. Black cohosh, soy isoflavones, vitamin E, red clover extract, all of these things are out there on the market being bought by people without a prescription. The American Menopause Society does recommend them as a possibility. However, clinical trial data have not shown them to be more effective than placebo. As far as medical options, you either can use hormonal or non-hormonal. Which one should you go with? Well, if you want to use a medical treatment, estrogen is going to be the most beneficial at helping with these hot flashes. However, if there is a uterus present, the estrogen must be accompanied by progesterone to protect the endometrium from proliferation. Estrogen can't be used in patients with an ERP-positive cancer or cardiovascular disease. Progesterone alone has been shown to be helpful with hot flashes in some studies as well. How are you going to give it to her? You can give it orally in many different preparations and doses. It can be given transdermally in a patch, also very effectively, and the advantage of transdermal is that it does bypass the liver, and there have been some studies showing that perhaps there's a decrease in venous thromboembolism going transdermally. You can give estrogen vaginally, but you may not get the systemic effect you want for the hot flashes. As far as non-hormonal treatments, SSRIs are probably the most helpful. There have been multiple studies showing them to be much in benefit over placebo use at decreasing the severity and the incidence of hot flashes. Paroxetine, however, should not be used in a patient on tamoxifen, as it may decrease the production of one of tamoxifan's most active metabolites. The remaining ones also have been shown to help in average doses with their various side effects that are published elsewhere. Gabapentin, definitely second line choice, definitely a good option for anybody who can't take estrogen or is on tamoxifen in the noted doses. clonidine, a blood pressure medicine, that can be given in a patch form for over a week at a time, or if the flashes are just at night, sometimes just giving it at bedtime can be very helpful without the side effects that it causes during the day. To watch this short presentation of a third-year medical student counseling a patient about her options, please go to YouTube under MRHAAKGYN. Regarding documentation, document the history you took, which would indicate the diagnosis you're working with. Document any physical findings that you might have noted. If you chose to do labs, certainly document those and what you're looking for. Treatment options, be sure to know what options she has based on your medical and historical findings and what option she chose. Now you have to set some follow-up. If the patient chose no treatment or over-the-counter treatment, you don't necessarily have to set a follow-up timer. It simply depends on what her symptoms are and whether or not she's still content with her treatment. However, if you choose a medical treatment, you want to be sure to evaluate things in a month. Within 4 weeks, the vast majority of women are going to get the peak effect of whatever treatment option you've given them. However, if you choose to use estrogen and progesterone, you may also want to reevaluate things after a few months to make sure that there are no bleeding issues with that particular combination. For chief complaint of hot flashes and more information both for yourself and the patient, the following websites can be helpful. This concludes the presentation.